Hello, everyone. Welcome to your lecture on the older adult, dementia, and delirium. These are the learning objectives that we will be covering in this lecture. These are some demographics about older adults. They're their fastest growing age group. By 2034, 65 and older, and older will be children under 18. And by 2016, 1 in 4 Americans will be at least 65 years old. And this shows us just how important it is for us as nurses to learn to take care of the older adult population. Some myths about aging, and these are very popular in healthcare. You hear them on the floor, in hospitals, long-term care facilities, assisted livings, all over the place, right? There are these myths that older adults are always ill or disabled, physically unattractive, they're forgetful all the time, confused, rigid, bored, unfriendly, unable to understand and learn new information. Maybe they're poor, even though stats show that many older adults are pretty stable financially. Another myth is that they're worthless after they leave the workforce. You're only good as long as you're working and paying taxes. Another one is that they're outdated in their knowledge and experience. And that is so opposite to the truth because there's so much we can learn from the elderly population. So these myths lead to stereotyping, and one of these stereotypes related to older adults is ageism. This is age-based discrimination, negative expectations of older adults. These can cloud our assessments, planning, and interventions. According to the World Health Organization, ageism shortens the lifespan, worsens physical and mental health for the elderly. It hinders recovery from disability, accelerates cognitive decline. It exacerbates social isolation and loneliness, and it reduces access to employment, education, and healthcare. All of these are negative ways that, ageism impacts our elderly population. So what can we do as nurses? Right? Assess your own attitudes towards older adults, your own aging, and the aging of your family, friends, and patients. Reflect on that. Form positive attitudes towards them, and get the knowledge that you need, the specialized education that you need to provide patient-centered care to them. Respect the older adults and actively always involve them in care. Don't always consider that they're disabled, they're not going to understand. No, talk to them. It's their health, right? They have the right to know. Do not treat them as objects. Treat them as independent and dignified people. Question, any prevailing negative attitudes in the culture at your workplace, right? And any stereotypes. Reinforce realities of aging, and gerontological nursing involves the provision of care that addresses mutually established goals for an older adult, the family, and the healthcare team members. These are extremely important points for us to remember when we are taking care of our elderly. Some aging theories, just for your knowledge, are wear and tear theory, genetic theory, cellular malfunction theory, autoimmune reaction theory. Then we have, psychosocial changes. These theories are related to that. For example, disengagement theory, the older adult. The disengagement theory, it basically states that, older adults, they gradually start, disengaging from society because they're either retired, they had debts in the family, or they have chronic illness or poverty. Then we have activity theory, Haviger's theories, and Erickson's psychosocial development theory, in which one should accept death as a part of the continuum of life and gain the virtue of wisdom. These are some, theories that we should reflect upon and see how they're embedded in our families and our cultures that we live in. Okay, so the leading causes of death amongst the elderly are heart disease, cancer, chronic lower respiratory diseases, stroke, Alzheimer's disease, diabetes, accidents such as motor vehicle accidents or falls, things like that, and influenza and pneumonia. There are 3 different categories of old, growing old, right? It begins at the age of 65. These are the young old, right? 65 to 74 years of age. Common issues that they deal with are retirement, healthcare barriers, like, they're sick and affects their ADLs, things like that. Changes in physical activity, the deconditioning begins. And then we have the middle older adult, which is from 75 to 84 years. Common issues that we see amongst this population is solitary, sedentary lifestyle. Oldest of the old, these are above 85 years of age. Common issues that we see in them are sensory impairments, oral health issues, inadequate nutritional intake, and functional limitations. So, what are some areas of assessment, for each system as you're assessing the older adult? Then you have developmental tasks such as adjusting to changes related to health. Like for example, they're fine and then all of a sudden they get sick and now they become weak and deconditioned. So how they adjust to that? How they adjust to retirement. Now they have a reduced income or a fixed income. How they adjust to the death of a spouse. They might, or children, siblings, friends, they might have some psychosocial, problems going on too. Accepting self as an aging person. It's a huge acceptance, right? We all want to be young and vibrant and, have a lot of energy to do whatever, things we want to do. But as the elder, people age, they have to learn to accept these, right? And just like, Erickson's theory, maintaining satisfactory living arrangements, where are they? Are they happy living there? Do they have the access to the resources they need? Or, things like that. Redefining a relationship with adult children and siblings, right? Their relationships change. When kids are young, your relationship with them is different as opposed to when they're adults. And maintaining a quality of life. And that's a huge one, huge developmental task for the elderly. The age-related changes that we see in the elderly are respiratory, cardiovascular, endocrine, integument, GIGU, musculoskeletal and sensory, the nervous system, cognitive, and personality changes as well. So these are some changes based on each system. For example, cardiac, they have decreased cardiac output, right? Increased peripheral resistance, so their blood pressure goes up, right? Increased systolic blood pressure. Then we have respiratory, their lungs do not have the elasticity they used to have, or intercostal muscle strength is reduced, their cough reflex is diminished. So all these things can cause them respiratory problems. Then they have endocrine problems where they have decreased insulin release, thyroid function, estrogen, and testosterone. So these affect, their health as well. Skin, they have decreased elasticity, so the skin tears easily. You have nail growth, increased dryness of the skin, thinning of the skin layers, nail thickening, hair thinning. GIGU, you have decreased saliva production. You have slow motility, gastric acid production, which gastric acid, as we know, we need to kill the bacteria in the foods we eat. Right? Musculoskeletal, they have decreased muscle strength, body mass, bone mass, joint mobility, and they have increased fat deposits, so they have less muscle and more fat. Right? Neuro, decreased nerve cells, neurotransmitters, their REM sleep is decreased, the blood flow to the central nervous system also decreases. Sensory-wise, they have decreased visual acuity, as we discussed when we talked about sensory. And, decrease hearing, decrease smell, decrease, like all their senses are affected. Cognitive, they have decreased short-term memory. They have an increased reaction time. Remember we talked about sensory processing. The reaction time is slow and increased. Information processing time is increased. Personality-wise, they're more cautious, right? Now they're going to get retired. They're going to be either widows or they have grandparenthood that they fall into. And so these are all changes, related to age. So which is a normal developmental change of aging? Go ahead and test your knowledge and I will give you the answer in class. So common health problems, as we mentioned earlier too, that we see in older adults are, chronic disease, osteoporosis, polypharmacy because they're taking a lot of medications, right? So they cause a lot of health problems. Then you have the depression because, now they're, maybe lost a family member, a spouse, siblings, children. They're retired and they feel lonely, right? And it leads to depression. We have the frail elderly syndrome, elder abuse, ageism, dementia, and delirium. We talked about ageism. So we're going to talk about frail elderly, elder abuse, dementia, and delirium. So how do we communicate with older adults? As you're doing your assessment, as you're, as their nurse, how do we do that? We first address them with respect, right? Orient them to the purpose and length of the interview. When you're about to start asking them, tell them, hey, this might take about 30, 40 minutes, and the purpose for it is, you just got admitted and we want to just develop a baseline for you and want to get to know you more, right? Give them time to respond. Don't rush them. Choose words based on the client's sociocultural background. So if their their cultural background is, for example, Hispanic, right? So just, kind of understand that. And if you need a translator, get an official translator. Keep the questions short and to the point. Provide nonverbal clues like nodding, direct eye contact, We should avoid patting and stroking because especially if it's culturally inappropriate for some patients. Active listening is a huge one as well. Please listen to them because they have a lot to share and we should take the time to listen to them. Teach them about, to shop during less crowded times. Some stores actually open up a little bit early to, accommodate the elderly. I think it's like, I noticed that at Sam's Club, they do that where they, open up early for an hour so the elderly can come and shop before the huge crowds come in. Slow down well in advance of traffic lights. Don't, teach them to drive safely that way. Staying in slower lanes instead of, staying on the left side where people are just speeding and getting annoyed, and we should teach, maybe encourage them to avoid freeways during rush hours, right? Because their reaction time is very slow. And so when things happen very sudden, they find it hard to maneuver, right? And if they have appointments, teach them to leave well ahead of time so they can take their time to get there and not be stressed or miss their appointment. We need to also discuss problems, family members may have in caring for them because, family members can get very exhausted and tired. And we as nurses, to provide patient-centered care, we always involve the family. The frail elderly, as humans age, they gradually are less able to adapt to internal changes, for example, disease, right? And the external environment. There are multiple systems usually involved. Frailty is a syndrome that describes a heightened state of vulnerability for developing adverse health outcomes. So basically, they are at high risk for developing adverse health outcomes. They're extremely vulnerable to these. That's considered frailty. Frailty is the point at which the human organism is believed to have its least capacity for survival and will fail in response to a minor internal or external insult. So they're very, very vulnerable and, less likely, the least likely to survive. For example, an example of that is a frail older adult might die merely as a result of an upper respiratory infection. An average person might get a cold or respiratory infection, go on antibiotics and be fine. But a frail older adult could die from upper respiratory infection, the same type of infection, because they're more vulnerable. So this is, basically what we call a spiral of vulnerability example. For example, their mobility is decreased, right? So they need an assistive device. They need gait response and reaction time, they're deliberate and slow. They're a potential victim for abuse, theft, and scam. And then they might have a fall injury, right? All these things, they're in unstable gait, using assistive devices, all those things, abuse, and all the, it leads to like maybe falls or injury to them, right? And for example, if somebody physically abuses them, they have an injury, or if they can't walk properly with their walker, they have a fall, right? So then they get hospitalized. And now when they're hospitalized, because they're so vulnerable, so fragile and frail, they can, get an infection or a pressure ulcer, and then they end up they can't go back home because now they're even more debilitated. And then they end up in a nursing home or long-term care facility, rehab. And then now that impacts them psychologically and financially, it takes away their independence, right? So every little thing counts for the elderly. So that's the reason why it's so important to make sure that we provide the proper care. So this is the clinical judgment model applied to care for the elderly. For all older adults, you want to check their ADLs, IADLs, any signs of depression using the geriatric depression scale, for example. The young and old, the young old daily routines, physical activity, conditions. For the middle old, you want to check function, any support system, what their social network is, how is their mental health. And for the oldest old, we want to make sure we, assess their physical and psychosocial cognitive abilities, social engagement, living conditions. There's a tool called Spices that is used, and we will talk about that in Skills Lab. And then jumping over all the way to, go ahead and read over this, but we're going to jump over to the action part of it. For all older adults, we want to promote independence and functional ability. They want to be functional, right? They don't want to be dependent on us. So we need to encourage that. We want to encourage cognitive function as much as we can. Keep them engaged, Don't just say, oh, they're old, they don't need all this. No, I mean, just things like crossword puzzles, things like that can help them keep their cognitive function alive. Illness prevention, communicate therapeutically, provide caregiver support. Because remember, the caregivers and the families, they get very tired and exhausted. We need to find out ways to provide support to them. And these are some other ways that we can, help and, interventions that we can take for all our older adults. And if you notice down here, the oldest old, you want to provide a supportive environment, modified adapted activities for them, making sure we give them the right nutrition that they need, and very important is to keep them safe. So this is, let's talk a little bit about elder abuse. Elder abuse is not good. It's not right, and it should be stopped, and it should be reported. Any suspicion of elder abuse must be reported to Adult Protective Services or the authority designated by law, and even if we have to call 911, so they can immediately, if you know that there's immediate life-threatening danger to them. Right? And these are some, websites and organizations that are agencies that we can report elder abuse to. When you're working for a facility, they have specific protocols for the facility policies, right? They might tell you if you suspect abuse, notify your supervisor immediately. And then the supervisor has a certain time to do this reporting to the agencies. So make sure you report it as soon as you suspect it or see it. So elder abuse is any intentional or negligent act that causes harm or risk to a vulnerable adult, right? It's seen in all cultures and socioeconomic groups, and they can be physical, emotional, sexual, financial, just neglect and abandonment. Elder abuse risk factors are mental illness, dependence on others, because now when they're dependent on others, people look at them as vulnerable and might abuse them. Right? If they're mentally ill, they might not be able to cognitively, live in the environment well. Past history of abusive relationship. Why do you think that's the case? Right? Why is it that a past history of abusive relationship puts them at a higher risk for elder abuse? Think about that, and we'll discuss it in class. Then risk factors is depression. They maybe just don't want to live, right? So they're okay with the abuse, right? Low self-esteem. If the caregiver is an alcoholic or poor health, stressed, has a low income, inadequate safe housing, lack of health insurance, if the caregiver has any of these, that can increase the older adult's risk for abuse, because obviously they're taking out their frustration on the most vulnerable. What are signs that we can see to recognize elder abuse? Maxillofacial trauma, like punches in the face. Like dental trauma also shows punches in the face. Subdural trauma, like maybe they got pushed and, hit on the head. Hematomas, periorbital laryngeal trauma, also, punches. Rib fractures, upper extremity injuries. Wasted and unkept appearance can be a sign of negligence. So what does it look like, the elder abuse? Like, it's battering, right? inappropriate use of drugs and physical restraints, force feeding, like in healthcare. These are things that can be considered adult, like battering the adult, inappropriate use of drugs and physical restraints, right? Force feeding the patient, or physical punishment. Non-consensual sexual contact with patients is also abuse. Treating an older person like an infant, including infantilizing communications, like it's called like elder speak, right? This can also be considered abuse. Giving an older person the silent treatment, like ignoring them, not talking to them, just, enforcing social isolation on them. Okay, we don't have time for you, you're going to stay in your room, and you close the door. That's abuse, right? Demeaning an older adult, neglect, abandonment, or financial and material exploitation, like improper use of an older adult's funds, properties, assets, or social security checks. Sometimes you see that in like long-term care facilities and nursing homes. So now let's talk about dementia and delirium. So typical aging versus dementia. Now, a lot of times these two are confused, and it's extremely important to understand the difference between what is normal aging and what is dementia, and something that needs to be taken care of, right? For example, with ADLs, typical aging, they're independent. With dementia, they become completely dependent, right? Forgetfulness incidents. In typical aging, they forget things, but then they recall it, right? But in dementia, they're unable to recall that. Concerns of memory loss, typical aging, the patient is concerned about memory loss, I always forget where I put the keys now, or I forget my appointments these days. So those are concerns that the patient will have, right? So that's just aging, growing old. Right? With dementia, normally the family has concerns because it's so bad that the patient doesn't even recognize it, but the family recognizes it, right? Word finding difficulties are occasional. Every now and then they're like, okay, this is what I wanted to say. Oh, I can't find the word to describe it, right? In dementia, it becomes very often. Pauses to remember their way in familiar places. Yes, but they don't get lost. They do forget sometimes, but they finally find their way, right? But in dementia, they lose it, but eventually, they also eventually, find their way. Ability to operate familiar appliances. And they're unwilling to learn new appliances when they're just part of aging, right? They're comfortable with what they're using. They're like, I don't need to know that. I'm just going to live with what I have, right? But with dementia, they're unable to operate even the familiar appliances or learn simple new ones. So for example, things that they used every day, they forget how to use those things. Like maybe the washing machine they used to use, or the stove they used to use. And that's why it becomes a huge safety risk, right? Level of interpersonal social skills. They maintain them, even though they're aging, they still try to socialize and do all that. When they have dementia, they lose interest in those. They behave inappropriately in social situations too, right? Then their, mental status exam, mini mental status exam for an elderly, usually with just aging, is normal. With dementia, it's always abnormal. So now let's talk about dementia and delirium a little. Right? I'm going to increase the size of this. This over here is, the difference between dementia and delirium. The onset for delirium is rapid, it's a short period of time, hours or days, it happens really fast. With dementia, like neurocognitive disorders, such as dementia, you have permanent progressive impairment in cognitive functioning, right? So it's permanent and it's progressive. It's just going to keep getting worse, right? What are some manifestations of delirium? They have impaired memory, judgment, ability to focus, ability to calculate, and it fluctuates throughout the day, right? In the morning, they might be fine, and then in the afternoon, you notice the patient looks a little confused, right? That could be delirium, right? Disorientation and confusion are often worse in the night and early in the morning, and that's where you usually see the confusion. They could have altered level of consciousness, and it can rapidly fluctuate, right? They can become restless and anxious, agitated. They can have fluctuating moods, personality changes, and the changes are rapid, right? They could have hallucinations, illusions, a change in reality for them. It can happen. They start hallucinating and they develop fear, panic, anger. Vital signs can also become unstable, right? That requiring interventions, and it can become a medical emergency. So that is delirium for you. With dementia, they have personality changes, they're confused, disoriented, there's a decline in intellectual functioning, and it's appropriate, decline in appropriate judgment and ADLs, right? Their coordination is not very well. So now they have impaired judgment. They have difficulty performing familiar tasks. They misplace things. Problems with abstract thinking. They have mood and behavior changes. So 4 A's of dementia are important for us to remember. You have aphasia, apraxia, agnosia, and amnesia. Aphasia is loss of ability to communicate. Apraxia, loss of ability to carry out purposeful movements, right? Like purposeful movement, like, okay, I'm going to get up and go to this room and get, this out of this room, like they lose that ability. Agnosia is impaired ability to recognize or identify objects, things that they were familiar with in the past, now they can't recognize them. And then amnesia is just forgetfulness, like memory loss, right? So then they could also have restless and agitation, and they tend to get like very confused and disoriented and agitated in the afternoons, right? It's commonly seen in dementia patients, and this is called sundowning. Right? Then you have vital signs. Their vital signs and level of consciousness are stable unless they're ill, right? You're not going to see this every day, all day, unstable vital signs and level of consciousness, right? But if they're sick, then you might see that, right? And people with dementia can develop delirium, right? It's possible. During sicknesses, they can develop, delirium as well. But if you notice the difference between dementia, delirium and dementia, changes are rapid and then they go away, they fluctuate. In dementia, it's pretty consistent and it's progressive and permanent. The different types of dementia are Alzheimer's dementia, basically, a large amount of beta amyloid plaques in the brain. Then you have vascular or multifocal dementia, which is ischemic brain lesions like ischemia in the brain, right? And this can be because of high cholesterol levels, hypertension, smoking, obesity. Then you have dementia of Lewy body, DLB, where there's damage to the nerves. Then you have frontotemporal dementia, also known as the Pick disease, where it all involves the frontal and temporal lobes degenerate. Diagnostics are cognitive testing. Risk factors are below here. If you notice neurological changes, like sicknesses, like fluid and electrolyte imbalances, then this is for delirium, right? Nutritional deficiencies, if they have like infections, severe infections, respiratory cardiovascular disorders, substance use, multiple comorbidities for polypharmacy. Delirium is very common in ICU units, and then surgery and restraint use can all cause delirium. But what causes dementia? Old age, family history, cardiovascular disease, depends on what kind, right? And then environmental factors like head injury, alcohol abuse, that can be your vascular multifocal dementia, right? Which damages your, circulation. Then you have strong genetic link in early onset familiar Alzheimer's disease, right? If you have family members who have early onset dementia, Alzheimer's disease, then there's a high genetic link, Then Alzheimer's disease greater than 85 years. And if you're greater than 85 years, there's, high risk for, if you have a family history of it, to get Alzheimer's. Right? Then what are the outcomes? Delirium is reversible. So how do we fix it? We fix the problem that is causing it, right? Prompt diagnosis, treatment of underlying cause. With Alzheimer's disease, dementia, a neurocognitive disorder, it's irreversible and progressive. And we have to be very clear and with the family as well. We don't lie to them and say, the patient and the family, that, okay, no, you'll be fine. It's just temporary. No, it's progressive and it's irreversible, right? What medications, treat delirium and dementia? With delirium, whatever is causing the delirium, those are the medications that we're going to give. Right? And we can give them a PRN for agitation and anxiety just till they become stable. But for the dementia, but for dementia, these are some common medications that are used. We have cholinesterase inhibitors like donepezil, rivastigmine, galantamine, memantine. Sometimes they're given, selective serotonin receptor, depression, antidepressants. Then sometimes at times they would need anti-anxiety medications when they're agitated, right? Now, if they have hallucinations, then we would use, antipsychotics. So these are some screening tools that we use for delirium, and these are some screening tools that we use for dementia. And common ones are functional dementia scale and BIMS and MMSE scales. And if they have depression, obviously we will use the geriatric depression scale. Now, nursing implications. What are things that we can do for patients with dementia and delirium? If your patient has delirium, you want to minimize risk factors. If they're agitated, restless, things like that, then make sure that they're safe. Minimize the risk factors of them falling or injuring themselves. Promote early detection. Notice when your patient is starting to get confused, right? Protect the client from injury, protect the client's dignity and quality of life. Have the client sit in a room with windows, to help them with time orientation, help them, come back to reality, right? Have the client wear an ID bracelet, use monitors and bed alarms for safety, use restraints only as their last resort. Just because they're agitated doesn't mean we need to tie them down, right? The restraints have a lot of, policies related to them on when we can and cannot use them. Use caution with PRN medications for agitation and anxiety, because now if we're constantly giving them, for example, lorazepam for agitation, then there's a high risk of dependence, right? And it does not really help with delirium. So assess clients' risk for injury and ensure safe physical environments, right? Now, for the patient with dementia, these are important nursing interventions that we should know and we should practice, right? We want to make sure, provide a safe environment for them, because especially, when they're, very far ahead, late signs of dementia, having those signs and symptoms, one of them is wandering. So you want to make sure that they're in safe environments. And that's the reason why dementia units and Alzheimer's facilities have lockdown units, so patients don't just wander off and escape. You want to administer screening tools for dementia and depression. Keep the client functioning and actively involved in social family interactions as much as possible. Don't just say, oh, they're not going to remember, whatever, we're just going to leave them alone, not bother with them. No, we want to, always keep them active. Promote cognitive function in them. Don't, give them activities, materials that are engaging, right? And requires some degree of cognitive processing. And you'll see that in dementia units where, patients are given like board games or coloring books, they read, they play a musical instrument. So, and maintain a orderly, ritualistic schedule to promote a sense of security. That is extremely important for patients who are suffering from dementia. Everything needs to be very orderly, ritualistic, by the schedule, because it helps them to remember certain things. It helps them to recognize, okay, now it's time to do this. Oh, every time the TV show ends, it's time for lunch. So you have to have that ritualistic schedule. Always want to display a clock or a calendar. I remember when I used to work with patients with Alzheimer's and dementia, we used to have a huge calendar. And at midnight, the staff, it was their task, an extremely important task. They had to go change the date on that huge calendar. It was, they would change the date, and the clock always had to be correct. As soon as the battery died, we would have to change it right away, because it's so important for them to have access to that, because it helps to reorient them to reality. Make sure the date and time are accurate. Use, life review and reminiscence. Talk to them about their family. Let them talk about their family, their life, their, things that were important to them, right? Keep familiar objects in the environment to promote a sense of continuity and security. For example, like family pictures. In some facilities, they give them this little box that the family puts memoirs inside that display box, and they put it by the door. So some patients, they would have little things like their pictures of their wedding, or their diploma, or whatever, was important to them, right? One patient I remember had this little glass jar with sand in it that she always kept because that was the beach that she went to on her honeymoon with her, with her husband. And now she was, sorry for that, guys. There's a glitch in technology again. Sorry. So, we want to make sure that we, remind them and let them talk about their family. Keep familiar objects, administer prescribed medication, like any symptoms that they're having, maybe they need some medication, so administer those. And communication, we talked about this earlier as well, speak to them in a slow, calm voice, avoid too much excitement because it gets them agitated, right? You want to stay calm, right? Use simple, short sentences, containing one idea each. If you say too many things in one sentence, they're not going to be able to follow, right? Avoid vague comments, be very clear with your, comments. So if the patient doesn't understand, repeat, your words exactly, again, until they understand. So provide supervision, manage difficult behaviors, assist with ADLs because they need that help, provide caregiver support, emphasize and support social activities. So this is the difference between dementia and delirium. So patient caregiver education. What do we want to teach our patients and caregivers? This is for us to teach, family members, right? What do we want to educate them? We want to educate them about the client's illness, how they can provide care for them, and how they can adapt the environment, home environment, to keep the client safe. How, things that we can teach them about a safe home environment include removing scatter rugs, like throw rugs, because they could trip on them. Put door locks that cannot be easily opened. Some actually have the ones, with the keys, so they can't leave the house until they have a key, right? Lock water heater, thermostat, or turn water temperature down to a safe level because remember, they're not, familiar on using these appliances, or they'll use, the water and it's very hot, it might burn their skin. Right? Provide good lighting, especially by stairs so they don't fall. Install handrail on stairs, like in the bathtubs, and sometimes maybe using just colored tape to mark the edges of the stairs can help, right? If next to the bed, they can place mattresses on the floor. So just in case they fall out of the bed, they land on the mattress, right? Remove clutter, keeping, things clear, wide pathways for walking through the room. Don't have like a maze for them to walk through. Secure electrical cords to baseboards. Store cleaning supplies in locked cupboards. You need to make sure that they're locked, not high cupboards. Remember, securing things in high cupboards protects it from children. They're not children, they're adults, right? So the only way to, keep those supplies, them from reaching those supplies, and maybe they look at Windex and think it's Kool-Aid, but because they're at that stage. And so you want to make sure they're locked. Install handrails in bathrooms. So let's test your knowledge. So if you look at some questions on your guided notes, you will see there are some questions. Please go ahead and answer those questions, and we will review the answers in class. And that is it, for old age and dementia and delirium. Go ahead and bring your guided notes to class, and I will see you then.